I'd like to introduce my co-moderator, Barbara Jasny, who needs no introduction to any of you who read Science Magazine because she is the prominent deputy editor for commentary. And Barbara, invite the panel 2 members to come up and join us.
Good evening, everybody. In this session, we hope to delve even deeper into the practicalities associated with implementing sustainable treatment and treatment as prevention. History has shown that strategies that work in theory in a clinical trial setting at small scale can run into problems in the real world. It is necessary to make successful strategies as efficient as possible in order to do the needed scale-ups with limited funds. We have here a group of distinguished speakers who will start with some brief remarks on their experiences and conclusions, but we're also hoping to leave time for some stimulating discussion among the panel members and questions from the audience and discussion with the audience. You all have the bios of the speakers, so I will not waste time in repeating all of their histories, which are extraordinary. We will start with Dazan Dixon Diallo, founder and president of Sister Love Incorporated, a reproductive and sexual health organization, who is chair and co-chairs of an array of committees dealing with services, dealing with sexual and reproductive health, microbicides. Again, let me turn this over to Dazan.
Thank you, Barbara. Greetings and good evening, and thank you for having me. And Barbara, thanks for that introduction. I first wanted to let everybody know I knew that if I lived long enough and worked hard enough, where's Tom? I don't know where he is in the room, that eventually my heroes would be my friends and colleagues. So I'm so glad to be here this evening. And would somebody please tell Mike he has inspired me to teach how to live in a PowerPoint-free zone. And if he becomes my first student, I'll waive his course fee. Because if I can win him, I got a good class. So just a couple of thoughts. In listening to all the incredible talks before and in participating in a lot of the panels over the last few days, as excited as I am and as thrilled and pleased to be a part of this process to share all the new news and the good news of where we are in the fight against HIV and AIDS, we do know that there's enough time, and there's not enough time, but there is a need to make the time to have the conversation about some of the challenges in terms of implementation, especially from a policy perspective, going forward before us. And I want to just maybe give a few pieces of thought that might provoke a few things. First, the first thing I said when we were having conversations not only about treatment as prevention, but about microbicides and about PrEP and about any other biomedical-based interventions and other types of interventions that could be available to us, is that no matter which way you look at it, everything about HIV begins and ends with behavior, and anything else comes in between. And I mean, I don't mean that just for the individuals that we want to get onto treatment and into care and eventually undetectable and non-transmitting, but we're also talking about the behavior of community, and that includes us as the researchers and the scientists and the treaters. We also are talking about the behavior of our governments and the behavior of our industries and the behavior of our society, and making sure that we're all working to get to that point. And so there are a few challenges in making sure that everybody behaves. So, and that's some of what we want to think and talk about, or at least in our circles in the work that we do with Sister Love. A couple of things that come to mind, for example, is that in terms, and I'm thinking domestically at this point, because that's really where I think our initial challenge will be. We're going to have to see how it works not only in Africa, but if it's not working for African Americans and Latinos and women and young men who have sex with men in the United States, then we're only working for other people and not for our own. And so I really want to make sure that we're recognizing the current challenges before us, even in terms of going forward. If we all decided tomorrow, which coming from Atlanta, Georgia, I'm always jealous of New York. Thank you very much. But if moving forward in the state, if we're looking at the South, for example, as being exemplary of some of the challenges we're going to have abroad, I think my region of the United States is a really good place to start in trying to figure that out locally or domestically. The Affordable Care Act, for example, does right now not a whole lot to give us hope in our region if the Medicaid expansion is not opted in by the states that we live in. And if the Medicaid is not expanded, even for those who are legal, who are identified and documented legal people in this country, for those who are undocumented, if we do not have a Ryan White Care expansion, extension, or reauthorization, then there will be a whole lot of other people who are not going to get access to treatment, and they're not going to be able to prevent transmitting HIV, no matter what we think about the brilliance in the science. And I think it's important for us to start talking about how maybe we're not thinking about them as illegal people, right? It's not enough to say that they are illegal, because their needs are not illegitimate. And so we have to legitimate the humanity and the ability to stop HIV, regardless of someone's status on paper. I would extend that to, if we're going to get to the end of this epidemic, including the use of treatment as prevention. Of course, I know what Mike was saying about a vaccine and a cure, but for some of us, if we can just give hope to folks that they won't transmit or that their partners won't infect them, that's a really, really big thing for people where I live and breathe and work. Well, if we don't get rid of the prostitution pledge in PEPFAR, well, how far are we going to get with people who are at the greatest risk when they become infected with HIV? So sex workers have to be protected the same way I'm talking about non-legal people living in the United States. Again, maybe by the time I get to this talk, get to the end of these comments, that we'll think about, oh, it's still about human rights. No matter what the science tells us, it's still going to be about making sure that we have all the appropriate policies, resources, and leaders and decision makers that understand the bridge between the science and the policies. And the other thing that I think is important is that we can end some of these silos, because now we have the opportunity to end the false dichotomy between treatment and prevention. I mostly do behavioral science, but I have been directly involved for the last 10 years in making sure that there is a bridge between behavior and biomedical and social and structure. And so if we continue to work down that vein, we have to make sure, for example, that the silos that are identified within the U.S. National HIV/AIDS strategy sort of have a cross-mix, hodgepodge. I saw a puzzle on somebody's slide earlier, that we puzzle them all together and see it as one. I also think another critical piece that we've left out for our own populations is the level of literacy needed to get people interested and engaged and understand what all of this means. We talk about it all the time. Even some of the folks who are in health education and folks who are the testers and folks who get folks linked into care don't know how to talk about HPTN 052. I have talked to an entire group of community planners who work for the states who had not even heard of Partners PrEP or treatment as prevention. And these are the folks on the front line. This is the community that we will need as our partners to make sure that the folks get to the care in order to get to zero. So I want to think of making health literacy the fifth vital sign. I don't know how long it took for us to add pain as the fourth vital sign, but I don't think we should take as long to add the literacy, how people understand what we're saying when we say it to them, that they understand that in their own lives, and that once we know their level of literacy, we'll be able to address them where they are, because adherence, obviously, as we know, is going to be the most critical factor. And then I'm going to remind you, as we move through what looks like in the United States, this unbelievable shift immediately from what we've known over 30 years of doing this work in a not necessarily connected, but definitely a comprehensive way of starting to focus so much more on the biomedical, that it still will be the community-based organizations, and it's still going to be the community health centers and the federally qualified health centers here and abroad that are the first point of contact, that are the people who are going to be meeting the patients that we need to get into care and onto treatment. And so again, we've got to make sure that there are protections through the resources, that there are ways to make sure that these organizations have a relevancy and a sustainability to get us into the realm that we want to be in that cascade of bridging the gap in the treatment cascade. And then I think the very last thing is that someday, hopefully before I die, the role of community-based participatory research partners will be recognized, will be acknowledged, and will be formally legitimized into all forms and all phases of research, whether it's basic, clinical, social, behavioral, implementation. Community partners are critical and important. There's an example just in the recently released HPTN 064, the ISIS study, where my organization, Sister Love, was the only contracted community-based organizational partner in the research design with our partner, Emory University, ended up recruiting the largest number of women in the study, maintained the highest level of retention, and now we have a whole slew of community women who are able to go out, translate the science, and talk to women in their neighborhoods about what this means in what I call the ISIS belt cities. So these are just some of my thoughts about how we're going to be moving forward into this realm, and I don't think, because I'm talking about the U.S., remember I'm talking about the southern U.S., which has a much shorter bridge to the global south than anywhere else in this country. So I don't think the experiences that I'm explaining or talking and thinking about in Atlanta, Georgia, are very much different from the conversations I have with the folks I work with in the province of Mpumalanga in South Africa. So we have to also remember that we've got to keep that bridge short so that we can keep crossing it until we're all in it together. Thank you.
Thank you, Daisy. Our next speaker is Jean Nachega, who is an associate scientist in the Department of International Health and Epidemiology at Johns Hopkins Bloomberg School of Public Health. He is also an ad hoc expert at the WHO in the HIV Treatment Guidelines Development Working Group, and elected member of South African Academy of Sciences. Thank you so much.
Good evening. I would like to thank the organizer for inviting me. I'm going to use a few slides just to put the scene. So this slide, I'm going to cover some challenges as we debate test and treat. And one of the challenges, you'll still remember the plenary of Tony Fauci. Some of the challenges he highlighted, adherence was a big issue. Adherence, there is no secret. It works in a dose-response manner. As shown on this slide, the higher adherent you are, the more proportion of patients who are highly suppressed. You had also the biological possibility between virological level and the transmission was provided by Tom Quinn in his paper in 2000. And what I want to highlight here, as on the previous slide, the dose-response fashion between the level of plasma, viral load, and transmissibility, basically which was the foundation of HPTN 052. But how adherent are we able to be? You still remember also this paper which made a lot of noise in the press, the JAMA paper by Ed Mills, was a meta-analysis comparing North America to Africa, showing that on average, North America, there is about 55% of patients having high level of adherence compared to 77% in sub-Saharan Africa. Regardless of the setting, the level was quite suboptimal, even if in Africa the level was relatively high. So the point here is that those levels are basically far from what was documented in HPTN 052. In a clinical trial setting, as Mike said, they try to optimize at the best adherence. Folks who are seen every month, folks who are not performing, there was counseling, intense counseling, so they can perform, as you can see on those on this slide. Just a quick mention also to PrEP study. You can see also there was a very clear dose response between adherence and efficacy. You remember the FEMPrep just been published in New England show a negative result, and adherence was quite a key in this result. Another wake-up call, basically, we provided at CROI data in pregnant women showing that on average, pregnant women are less adherent during pregnancy and they become worse after pregnancy. There was also data on retention provided by Landon Meyer IDEA cohort showing that high loss to follow-up in pregnancy as well as post-pregnancy. So there is an issue in this also vulnerable population. The cascade you saw from New York, here I just show some challenge of our cascade from the South, middle and low-income country, from Burundi to Botswana to Uganda to Namibia, Malawi. After 2 years, we lose about 20 to 30% of our cohort. So this is unacceptable. This is not the way we can do a test and treat. We need really to think hard how we can fix this issue. So let me now, I show you some key challenges. Let me switch on how we think we can help in the test and treat. A group of international experts came together to try to provide some evidence base to try to improve adherence and retention. And as we move along, we're going to update this guideline as more evidence are available. Needless to say, we don't have any gold standard to monitor adherence. There is always pros and cons of different methods. The most practical, easy, self-report, pill count, pharmacy refill have their caveat, as well as the more somewhat objective use in research, like MEMS caps or drug level, or more recently, this type of device, which not only record each time patient does not open its a container for medicine, but also send a message, an intervention function, if the lapse is more than 48 hours. So I think counseling is something that we have for the first time evidence that it can make a difference. These are data from Kenya showing that folks who have really targeted counseling 2 sessions at baseline and monthly for the first few months after starting HEART compared to standard of care, which is just 1 baseline counseling, there is an impact not only on virological outcome, but also on adherence. This is more exciting area, which I think the West can learn from the developing country. Those are also high-profile study published in the Lancet from Kenya, funded by CDC PEPFAR, the mobile phone WellTel RCT, showing basically that the mobile phone can make a difference in improving patient adherence. And there is another study, which is the Christian populations, also from Kenya. So this is basically what it was about. There was a kind of interactive function also reminding the patient if does not, a patient have to say yes or no if he did took in medicine. How about improving adherence? Regimen simplification is an exciting area nowadays with now 1 tablet once a day. You familiar with Atripla, there is more coming. And I think we just presenting at this conference a meta-analysis basically confirming with about 21 study that 1 tablet once a day improve adherence, but also virological outcome. You remember we come from a long way from really the heroic era that our patients were experiencing to now once a day. I think those are tools that we need to use. So I'm going to stop here and look forward for more communication. Thank you so much.
Our next speaker is Donna Futterman, who is a professor of clinical pediatrics and director of the Adolescent AIDS Program at Montefiore Medical Center, Einstein College of Medicine in the Bronx.
Thank you. It's a great honor to be here at Science. I mean, it's certainly a place that all of us, and a magazine that all of us have revered throughout our scientific lives. So thank you for having us, and also a great honor to be with so many esteemed panelists from before and now. we all first have to give our explanation about slides. I decided not to do slides because I thought the audience would groan if at the end of this long day and two panels, another set of slides came up. So I decided to just speak. And I really want to talk about three things tonight. The first is how, if we're going to really achieve the benefits of treatment as prevention, we can't ignore or assume we know what to do about the first step, which is addressing the gap between those who are infected and those who know. Second, I want to describe some of the experiences that I've had over the past 8 years of trying to scale this up. And then I want to conclude with some thoughts about young people who are the new tip of the epidemic. And before I get into this, I just want to say there's really, three concepts being batted around. One is the idea of research. Then the scientists realized we have to do implementation science because we have to understand how the research will be applied. But I think, I really believe that the part that's not spoken or given enough credit is actual implementation, not implementation science, and that we're going to really need to be challenging ourselves as to what really needs to be studied as implementation science versus what needs to be implemented and carefully monitored. Because the expense, the effort, and in a way the delay and scale up that comes from the type of studies which are fantastic in giving us information, but we truly are in the midst of an epidemic in which we have to consider what needs to move forward. And not to challenge my colleagues too much, but here was an example that just seems so disturbing to me, that a major study is about to be funded on patient navigators. And how could it not help patients to be assisted throughout the course of their disease? And I think in an era in which we're losing funding, in which the world is funding us less, that we have to really challenge ourselves to what do we need to do to end this epidemic, and what do we need to learn just for the sake of learning it. And, I want to put out that I became very interested in implementation because I think we can apply the best of what we know in a more powerful way. So back to the first point, which is about the first step in the cascade and that difference between the people who the people who are infected and the people who know, and that small group of 20% is thought to account for 50% of new infections. And I think in many, many ways, our healthcare system has still not stepped up. In its most fundamental way, HIV is a medical disease, and the healthcare system has to wrap its brain around it. We represent the AIDS world, a very thin slice of the medical world. The much broader world really still doesn't care about what we're doing. And that's the group that has to be mobilized and engaged. If we're ever going to get routine testing, it's not going to be at AIDS programs. It's going to be in general and routine health care. We still face, and, I've just seen it over and over again in the Bronx, in South Africa, a tremendous amount of provider resistance to bringing HIV into their work sphere and into their sphere of influence. And I really believe that if we are people go to a doctor because they expect to be told what to do, and many people who go to a doctor and have blood taken assume they were tested for HIV. I'm a doctor. I do not go to my own doctor with a list of what they should do for me or request a test. I expect the doctor to tell me what to test for. And I think until we really bite the bullet and move to the final paradigm in HIV testing, which is to make it as routine as anything else in the healthcare system, we still have a separate consent system. We still have a separate tracking system. We still have a separate counseling system. And I don't think we're going to beat this first step in the cascade until we move HIV testing to be a checkbox. And that's going to be a radical concept because I think there's a lot of people who will be very threatened by the idea of not providing counseling. But in my experience and in what I've seen in repeated settings, if we do the kind of task shifting that takes the HIV counselors, put them into linkage to care, put them into adherence counselors, we will have a much more efficient use of our dollars and a much stronger impact on the epidemic. Second, I want to talk about the experiences I've had since 2004 in scaling up counseling and testing. And long before there was proof it worked, we knew that the more people knew their status, that was the thing we had within our grasp to help people become engaged in care. And just by knowing and being engaged in care, they would reduce their high-risk sex behaviors 50%. And then clearly now with the new treatments, it's clear that getting treated will help reduce the spread of HIV and, most important, support their health. So we created a program because we asked providers, why aren't you doing testing routinely? And they said, I don't have enough time. I'm not aware enough about HIV. I don't have the experience to do it. These are full-on doctors and nurses who thought they knew less than counselors. And that wasn't their fault. That's what we had created. And we created a system to use the knowledge that providers already had, but we also knew we had to streamline the counseling and testing process in order to be able to accomplish this. So we developed a 4-letter word, ACTS, A-C-T-S. It stands for advise the person to get tested, get their consent by whatever law is in place locally, do the test, and here's what you need to do to provide support. That final S for negatives and positive. And this was something that we learned we could apply in the exam rooms and encourage doctors and nurses to use. The other half of our ACT system was pretty basic information in how you do a practice change. First, you have to get buy-in, and buy-in is not a once-off process. It's going repeatedly back to the highest person in the system and every single person throughout that system. You then need to do planning. How are you going to implement counseling and testing? What is the literal flow of the patient, the literal flow of the HIV test? How are you going to get people involved in this? Next is training. Very simple. We can do in one, HIV test training for counselors is a week. We can do in a day or in half a day training of healthcare providers to learn how to provide quality testing to the patients. And finally, you have to monitor. You can't know what you're accomplishing or not without monitoring. Each of the places in which we implemented ACT's system, we went first to places that had good monitoring systems. Our principle in this work is utilize existing resources. And we did this with education money. We didn't do it with research money. I know how to do research. I get plenty of money for that. But this is something that didn't require that. It required implementation and going out and doing it. We began in 2005 in the Bronx and in 2008 in South Africa with a PEPFAR grant and an educational grant. In the Bronx, we began in primary care institutions at Montefiore Medical Center. The Bronx, for those of you who don't know it, beyond that it was the home of hip-hop, which we love, the Bronx has 1.4 million people. It's a fantastic community like the Africa Center that was described. It's well characterized. We have a network of providers who've worked together historically. There's a lot of mutual respect between the medical and the community institutions. But we picked primary care sites, and we had 10 of them. We randomized them to early starters and late starters. At the beginning, back in 2004 and 5, no clinic was testing more than 10% of its population. And over the course of doing this work, existing resources, training, existing monitoring and evaluation, we increased testing from 32,000 a year to 64,000 a year. We doubled the testing and are now reaching 30% of the people. But that's not enough. 30% of the people coming in for medical care was sort of the best we could do in any of these settings. So we have to keep tweaking the system, and the monitoring allows us to see we got to a great level, but we didn't get far enough. So we had to engage the political system, and we still have to engage. New York, as Blaine just said, made a law that mandated the offer of testing. And this law makes us have to do it, so we go back and get buy-in from the hospital, which now is committed to making testing possible. In South Africa, we worked in the Western Cape Province with Cape Town, the capital, and the AAAS model and provider-initiated counseling and testing became the policy in 2009. And testing increased from an average of 320,000 a year in 2009 to 540,000 in 2011. Now, that increase was not just the AAAS program and the work we did, but it also reflected a national campaign for testing. So we have to have a lot of approaches to increase testing, not just the provider model. And what showed us that we were having an impact was that in the second half of 2011, after the campaign was over, we still are at an annualized rate of over 500,000. So we've, again, almost doubled the testing that we were able to accomplish through provider training. The last point I want to make is about young people. And young people are, what can I say? We're seeing a resurgence of this epidemic in youth. The only group in which cases are going up is young people 13 to 29. The CDC just reported that while among adults about 20% don't know, among youth 13 to 29, a full 60% don't know. So in addition to provider-based testing, we have to do a lot of work with targeted testing. In our clinic in the Bronx, of all the new young men who have sex with men who come in, they've had an average of 5 prior negative tests. Testing alone is not a prevention strategy, yet testing has to be there to get them into care as soon as we've tested them. So we're going to need things like youth empowerment and leadership. We need to fight homophobia and racism. We need to socially market and use social media for messaging to young people. And all this is because there's a new generation of young people every 5 years. So what we did 3-5 years ago doesn't matter to the kids who are in high school today. We have to start out, give it to them as energetically and as powerfully as we did each generation, or we're going to watch another generation of young gay men be wiped out by this epidemic. Thank you.
Let me now introduce John Blanford, our last speaker. He is Chief of the Health Economic Systems and Integration Branch in the Division of Global HIV/AIDS of the U.S. Centers for Disease Control and Prevention. Thank you.
And you get to groan twice now because not only do I have PowerPoint slides, but you're going to get an economist presenting PowerPoint slides. So but I guess in a sense it's appropriate because I'm going to we're hired to deal with constraints and optimize within constraints, and now you have both a time and an energy constraint that I'll try to respect here. So really, within CDC, among our functions is to provide, sort of primary technical support to the Office of Global AIDS Coordinator under PEPFAR. And so we occupy that space between science and in order to inform policy and planning. So in a sense, I'll have a foot on the a pier and a foot on the boat, which, as you know, is a dangerous place to be. And just to talk a little bit, sort of how we responded to the news of OVI2 when it came out on, I believe, May 11th, and then literally scrambled within a week or two to start a process of doing those analyses to basically look at these questions of value and optimizing within the resource constraints. I need someone older, Nancy? She's sort of gone. Right? There you go. Got it. Oh, these are my old slides. Okay, well, just to this is like another reason. That's fine. I'll move quickly through these. This was the issue with PEPFAR, basically a rapidly growing program hitting 3.9 million in 2011. The flattening resource envelope. We like to call this our perfect storm. And so you saw what was happening with the resources and the rapidly growing program, and then the perfect storm was added with 052 coming with this great opportunity we had programmatically and how to deal with that. The upside was that this is, again, the blue line showing the scale up of treatment under PEPFAR. The green line's the good news, which was the unit cost over time, from nearly $1,100 at the start of the program, for the cost of PEPFAR being under $335 by 2011. So we had some hope for that we could had additional room to grow, but had to look at sort of what the case could be made for that growth and what was the value in expanding growth further. So first, I just wanted to talk about sort of the societal benefits and the estimation of those. One of the things we need to do is to articulate within to our stakeholders, to legislators and other stakeholders of PEPFAR, what you were getting with the value of treatment. And in some ways, I'll differ a little bit with Till's work. Out of his work is really exciting in terms of the benefits for mortality and incidence and employment and wealth, household wealth. But one of the things in a sense, I differ with the treatment as prevention formulation in a sense that we're not doing treatment simply for prevention. We're doing treatment for the benefits of treatment, which now include prevention, that we can quantify. And so that we were trying to do is articulate what was the value in providing treatment within PEPFAR and more broadly, and put that in a simple metric that would be meaningful to the stakeholders. So what we did was estimate for every 1,000 patient years of treatment, considering those benefits not only to the patient, but also the indirect benefits for averted sexual transmissions, vertical infections, averted orphanhood, and estimate what those benefits would be. So for every 1,000 patient years of treatment provided, we estimate 228 patient deaths would be averted in sub-Saharan Africa, 449 children not orphaned, 61 sexual transmissions averted, 26 vertical transmissions averted among women who simply became pregnant while on treatment. And then 9 TB cases averted for an estimated discounted life years of 2,200 per 1,000 patient years of treatment. And so provide that simple metric and then estimate what the averted costs were. And these were the savings that didn't come back to PEPFAR but came back to society more broadly. And then when you consider all these costs, it offset approximately 59% of the total treatment program cost in 2012, with the net societal cost of treatment per discounted life year gain of approximately $168 per patient year. And so based on WHO standards, this could be considered highly cost-effective in sub-Saharan Africa. The work that Tills and Steve Resch and others and Harsha Thurmurphy have done in terms of the productivity gains could actually flip this over into the place of being cost-saving. So if you're doing treatment solely for the purpose of prevention, it may not be the most cost-effective way to do prevention. If you're doing treatment for treatment, when we have coverage rates under 350, the great news at 56% in sub-Saharan Africa, which is astounding. I mean, I can't believe I'm sitting here saying that. But at the same, we still have room to actually treat people who still need treatment for their own health. And these are the additional benefits, mentioning Steve Resch's work and Till's and others. The other piece was to understand that this isn't free. We are in a resource-constrained environment, and to basically put the challenge out of if we could further drive down the cost of the program, how much more program could we buy, and what would be the potential epidemic impact? So that at the same time, we would love to see the resource envelope grow to still understand that we have resources within the system, and how can we make best use of those? So we did an example, really, again, we started this with John Stover just a couple weeks after 052 came out, to say basically looking within, if we took a public health approach to treatment, we could, and working with the folks in the treatment branch, and both in country and in Atlanta, we felt that there was room to actually drive down cost another 25%. We looked at Kenya and Zambia because they were countries that already had good coverage of male circumcision, good coverage of prevention of mother-child transmission. So we're just looking at the incremental impact of scaling up treatment. And we didn't have guidelines yet from PEPFAR, but we're just looking at groups that were already in the system. People who are already in pre-ART care, raising the threshold to 500, lifelong ART, option B plus for pregnant breastfeeding women, regardless of CD4 count, patients with active TB, and people in known discordant couples. So it basically increased the patient rolls in Kenya by about 50% over 5 years, or adding an additional $323,000. And then this was basically, this is the trade-off slide. If we do nothing about the program, maintain our unit cost at the same rate, maintain our coverage at the same rate, we're going to see the red bar, which is basically the steady uptick of the total program cost each year. The green bar is basically the trade-off. If you're willing to try to push down the unit cost more and at the same time accelerate the number of people on treatment, you do get an initial spike in the total program cost. They flatten out over time, and in the next decade is where you really start to see the savings, because those are the infections that don't occur in this through the 2020. 8 to 10 years later, you're now averting those costs of treatment. And this was then the potential effect on the incident infections, which was, we were projecting approximately 31% over 5 years' time with the accelerated treatment. And so again, just to emphasize, this isn't costless, but to get a sense of what's required. I sort of share Tom Coates' evaluation, and I was just talking to Christine Levinsky before I came in and said, in some ways I feel like that we don't even need to do this presentation today, because there's been these first couple of days, we're like on Tuesday, and just the sort of level of excitement and consensus you're already feeling kind of converging in this meeting. It does feel like a transformative moment, and I guess I will stop there. This actually, just one final slide. I forgot I had this one was in this presentation. There's been a lot of focus on how we went through this really rapid growth. This is total global development assistance for health. And we noted the really rapid growth in the years, starting earlier in the epidemic, the flattening out with the flattening out of Global Fund and PEPFAR resources. And so people are really focused on the flattening and the increase. I think that the other thing to consider, though, is think about what's happened in those 6-7 years beforehand with that rapid acceleration. We have to know that there's ways to still optimize with that growth of global health assistance. We're not seeing health assistance decline, but we've seen a flattening in the growth. There is still some room to optimize and get more out of our programs. And that's it. Thank you.
The hour is late, but I know my co-moderator, Sten, and I would like to leave time for questions. If there is something that is burning in your mind, let me bring panelists up.
Yeah, it's just a quick question because I'm from the Philippines, and it's one of the 7 countries in the world where HIV is still rising. We've only had 10,000 cases since '84, but half of those were in the last 3 years. And I came home from the United States in 2008, and I ran smack into an epidemic, and it's MSM's, kids dying, basically, like San Francisco, basically. And I produced a rock concert, which is featured in Science, by the way. I've talked to leaders and everything. So it's really a big advocacy, media blitz, and then taking care of the patients themselves. But, at some point, I just get really burnt out. So I can feel your energy from across the room. So I really want to know how you keep it going. I mean, right now I'm getting sick. So, I just wanted to tap your brain on that. Thank you.
That is hilarious. Usually when people ask me that, I said, please don't ask me that, because if I stop to think about it, I will not get started again. Honestly, it's really, really just what I understand is what I'm supposed to be doing in life. And if I stop doing it, then I don't know what else would make my life worthwhile, honestly. And the other thing, though, and it's interesting because I didn't have a lot of time to do it today, usually when I speak, the first thing I do is I call the names of just about every single woman that has passed in this fight against HIV and AIDS, because every time I do that, it just reminds me and grounds me. But I'm one of those that I'm in it till it's over, whether it's a marriage or something else. And so, see, that ended, and I'm still, I'm best friends with him, so I'm still in it. But no, really, this is just a commitment that I want to win something, and I want to win this. And I think if I'm a part of this world community that cares enough to bring HIV to an end, it means that they've cared enough to end violence, they've cared enough to end racism, they've cared enough to end sexism and homophobia and poverty, and that it's not just, I don't want to eat the elephant one bite at a time anymore. I want to grab both my hands and throw the chunks in the mouth. It's got to work. So that's really what it is. It's an energy of everybody else around me and the desire to say one day that I was a part of the end of that thing. That's all.
Yeah. I think, given the lateness of the hour... there's another question. Yes.
Thank you, everybody, for the energy, the excitement about these new upcoming studies. It's tremendously exciting for us to hear about. One quick question for, I believe it was Tom Coates who was talking about as part of Project Accept.
I'm talking about, sorry?
Part of your Project Accept description, talking about keeping the people on the front lines inspired, motivated, incentivized, your HIV counselors, your people who are dealing with their community members, dealing with the patients, keeping them motivated. How do you do that year after year, year after year? You talked about them wanting to only bring in 2 people who are positive versus 8 people who are positive. I think this is something we're seeing in program levels.
I think it relates to the previous speaker's answer. We had, as our plenary speaker for Global Health Awareness Week, a gentleman named Richard Blum. You may not recognize his name. He's president of the Board of Regents of the University of California, and his wife happens to be Senator Dianne Feinstein. He is an equity trader. He's made a lot of money, and he's given a lot of money. And I said, Mr. Blum, how do you keep on giving? And he said, given the tremendous drain in the world statistics, and it seems like the world's out of control. And he said, well, as a Jewish Buddhist, I'm going to quote Christ. And he said, you pick a spot and you make a difference. And that's what I've done. I've picked some spots that made a difference. And that's what we try to help our counselors do, is to say, we're picking a spot, we're trying to make a difference. It's hard work. And I think we get out there on the front lines with them and talk about that, and talk about this drain, and talk about the drain, and talk about the next person coming in who may be HIV positive, who may break down in tears and not know what to do. And we give people breaks. We give people time off, but we say, all of this is about making that difference, and making that difference is finding those infected people and helping the uninfected people stay uninfected, and that's what we do.
One of the great hopes of HIV treatment around the world is that it would raise the standard of healthcare for everyone for a variety of healthcare needs. That said, implementing a Western style, monitoring CD4 counts, viral level, second line drugs, all that, and implementing it in resource limited settings is pie in the sky type of thing. So we're talking about task shifting, not monitoring CD4 levels. I mean, what are the, if you will, the 2 different plans? So what does a resource limited plan look like? In your view, that is effective, that's pragmatic, but at the same time will, raise standards of healthcare. I mean, what are you hearing? What will that, implementing this, what will it look like?
I just want to start off by reminding people, or just suggesting that with every advance in HIV sort of treatment and response, the initial reaction was always, we can't do this in a resource-limited setting. We just can't do this. This will never happen. And it's true that oftentimes it happened in a first-world setting first, but eventually that shift has happened. If we think of highly active antiretroviral therapy, if we think of the scale-up in HIV testing and prevention of mother-to-child transmission, these were all things that people said, this can't happen on a big scale. So I just want to put that out there as a very hopeful thing. The time frame may be a little bit different at first, but not to think it cannot happen.
Yeah, I would like just to add, I think we are, as someone said, we are living really exciting times. And for someone like me living in a resource-limited setting, like South Africa to some extent, even if South Africa may be considered, compared to other African countries, a bit luxurious, also a place to be, but still limited. I think the major priorities are basically to try to increase the people who are to get started on heart. You saw the latest figure from low-income country, about 8 million are on heart, but the gap, there's still about 10 million who still also need to get on heart. So we still have a lot of work for people who are eligible, so that is CD4, based on a recent WHO guideline at below 350. So the priority will be basically to reach those people. We're doing good job in peri-urban, in cities, but we're still doing poor job in rural and remote places. So we need to think creatively how to get people tested, how to get them on heart. And as you saw from the cascade I show you, which is the same challenges you have here, is how really to make sure the cascade at the end of the day is successful. So now how to try to match now the advance in sciences. And I think we need also from Africa to move with the science, but recognizing the reality, and we cannot be left behind. And I want to insist here, we don't jeopardize the quality. And we are, the first move was, first of all, to try to move from toxic drug like D40, which now has been phased out, to have tenofovir-based heart as first line in most of African countries. I think that was quite a big move, and most of countries are following. And now, test and treat, how we embrace that. And I think WHO is doing a great job to try really to come up with some guideline, which is going to be delivered, I think, next year. This is going to be incremental. So basically, the plan will be, as we are trying to cover people who are urgent need, we need to think at other populations, special population, and I think the priority will be to think at, pregnant women, discordant couple, and at some extent, men who have sex with men and commercial sex worker. It's not going to be easy. There are going to be challenges, but we cannot act. The issue will be how to reach those populations, and because there's still some challenges. Pregnant women, I told you, after delivery, about 20% are lost to follow-up. Regardless, there is code from South Africa, code from Zambia showing it. When you move to men who have sex with men, in Africa, those are a population, when it's about PrEP, there's still some issue about stigma, issue about, human rights. In some country, they are quite criminalized. So how to try to challenge those kind of attitudes which basically fuel the epidemic. When it comes to commercial sex worker, they still also issue about stigma and human rights. In some country like South Africa, it's not legal. It's, commercial sex worker is not legalized. So there is challenges, but one need to try to see how to work them out. But no doubt, we need to. My point is, we need demonstration projects. So I was really happy to see those cluster trial ongoing, and I think the next phase will be to try to move in real life setting with a demonstration project as we increase people on heart, the treatment access.
I can grab this, I'm sorry. I heard both resources and health systems, so I feel like I have to respond. Well, I think one of the things, to point out that one of the things that drove down the financial cost to PEPFAR over time was there was a lot of money spent up front basically rebuilding health systems in order to support the scale-up of services and laboratory facilities, health information systems, M&E systems, and the like. And I think there's an interesting paper in Health Affairs, too, by Margaret Cook and others in terms of the crowding in effect for services non-HIV patients, which is exciting news because we didn't know which way this is going to break. And I know it's still, it's one piece of evidence, but it's actually very important. I think the thing to think about is when I think about resources, it's not just about money. It is actually about real stuff. And the limitations in sub-Saharan Africa are human resources, infrastructure, and the like. And those things that are burdens to that stretch the human resources and the like are also the things that stretch put the burden on the patients. Time and travel cost. It's the frequency of clinic visits. It's all those pieces. If we can get, that's why I'm kind of excited about some of the things. CIDR's work that showed you might be able to safely extend clinical monitoring intervals for stable patients. The MSF pilot in Mozambique, which is doing community pickup of ARVs, which basically, people get together, nominate one person out of a group of 6 to go in and pick up the ARVs each month and rotate and do community pickup. And the workers, healthcare workers, are reporting they have more time because they're only seeing people every 6 months rather than every month. So it's one of these things to kind of think about what are those innovative ways that actually lower the burden and stretch the real resources, not simply the financial resources.
My final comment is just to say that we can be optimistic about the science. We can be optimistic about the positive energy in this conference with fresh data and exciting developments. But there's a lot of talk behind the scenes in Washington and in our fair city here with terms like exit strategy, terms like treatment mortgage. These are codes for how is the U.S. government going to substantially diminish its investment in PEPFAR. Everybody will deny that they have any intention to do it, but these are the buzzwords that are around in this town. And I think those of us who see this the way that our economists do, Till and John, as actually a tremendous investment. This is a humanitarian investment, but guess what? We're finding in your analyses precisely what the Brazilians found in the mid-1990s when the Brazilians decided, pre-PEPFAR, pre-Durban AIDS meeting, that they were going to invest in ART for therapy because it saved them money overall. It cost the money for 3 years, and the next decade of projections was saving the money. I think we're going to have to be clever on how we present this, given the political atmospheres in this city, to not only be the warm and fuzzies as to our memories of taking care of some of the sickest patients we ever took care of in our lives, which was my experience in the 1980s, but also to think about how we're going to make effective, hard-bitten economic arguments that ministers of finance and congressmen down the street are going to appreciate.
Any other final comments? Yeah. Then I think that's an excellent ending point. Thank you very much for attending. Thank you to all.